I will hand over to Debbie to continue from where she stops.
Okay. Thank you, Ed and Noah. It's always fun to do the AGM, right? Okay, I'm pleased to introduce Dr. Anastasiya Muntyanu. Sorry. She's a Canadian and US board certified dermatologist currently practicing in Toronto. And she's joining us today, which we are grateful for. She completed her medical school at the University of Ottawa and graduated from the University of Toronto Dermatology Residency Program. She is completing her PhD focused on studying environmental triggers of autoimmune and inflammatory skin diseases, including psoriasis, systemic sclerosis, and atopic, I think this thing's cutting out, but anyways, and atopic dermatitis. She has over 40 publications in high-impact journals and has received numerous awards, including from the Canadian Institutes of Health Research Award, Canadian Dermatology Association, and American Dermatoepidemiology Network. Please welcome Dr. Anastasiya Mutyanu.
Thank you so much for the kind introduction. So I'm really honored to be invited to present here today. Scleroderma is actually very near and dear to my heart. I have one of very close family members living with scleroderma. And so before I was in medicine or going down this path, I kind of watched them from back then to now, and going through medicine, I tried to learn as much as I can about scleroderma, and my PhD work is related to scleroderma. So I'm really looking forward to sharing this with you. And Winnipeg is also near and dear to my heart. My husband's family is from here. And back when I was a little girl, I would come here for training camps for rhythmic gymnastics. So I've been here a few times, and it's always a pleasure to be back. The weather's beautiful today, so it's very welcoming. So for the outline of the presentation, we'll talk a bit about scleroderma, then we'll talk about the clinical presentations and the treatment options. And there's, of course, many options that exist, but I'll try to focus on some of the newer options that are in the literature that you may not have heard about, and something that we're able to do in our clinic. And then we'll talk about the environmental and occupational triggers of scleroderma. So there's a huge rise of autoimmune diseases in general, and we don't really know the reason why. In a large study having 22 million patients across 19 different autoimmune diseases involving the gut, the joints, the skin, the trends are all increasing over time. Some of the hypotheses for these factors include stress, climate change, air pollution, foods, but really we don't know the reason why this is happening, and that's why more research is needed in this area. And the skin is the largest organ that we have, and it's constantly in contact with the outside world. So it's the ultraviolet exposure, the toxins, the air pollution, excessive water exposure, and other factors come in contact with the skin on a daily basis, and that's why these factors could potentially trigger skin disease. So systemic sclerosis, as you all know, is an autoimmune disease with fibrosis leading to thickening of the tissues. It usually starts at about 20 to 50 years old, and it's much more common in females, so about 4 to 8-fold higher rate in females compared to males. And the most common organs that are involved are the skin, the lungs, and the GI tract. So again, those are all the organs that are always in constant communication with the outside world. We inhale the air, we eat the food and things that go through our GI tract. So it's important to think about those environmental factors. Now, it's a very rare disease, and the prevalence, or how common it is, varies greatly between in different parts of the world, so anywhere from 7 to almost 500 cases per million individuals. So we got an excellent overview of this morning from Dr. Cameron. But just to highlight again, because it can be quite confusing if you're reading information out there. So systemic sclerosis is known as scleroderma, and then we have morphia, which is also known as localized scleroderma. So systemic sclerosis is usually divided into two main forms, which is limited and diffuse. So limited is when there's involvement from the forearms to the fingers and from the knees to the toes, and then also involving the face. And then diffuse is all of the skin surface can be affected, including the face. And on the right-hand side, that's an example of a morphia plaque. So that's the most common variant of morphia. We won't get into the different variants, but it's these individual plaques that can occur anywhere on the body. And so really the main distinction between these two conditions is the systemic involvement. Other differences, so Raynaud's that we'll talk about shortly, occurs in systemic sclerosis. It's symmetric, as we see in the photo, kind of both arms, both legs, or diffuse. Thickening of the hands is seen in systemic sclerosis. Facial involvement in systemic sclerosis. And then systemic we talked about, and some specific autoimmune antibodies that we look for are present in systemic sclerosis, but not in morphia. So dermatology is a very visual specialty, so I'll go through a lot of photos. So first we'll focus on the manifestations that can occur on the hands. So over here we have a photo, and it's hard to appreciate this, but the fingers are quite puffy, and when there's pressure applied to the finger, there's almost an indent that forms temporarily. And this is usually found in the very early stages of systemic sclerosis. Over time, that can progress to thickening, and so difficulty to mobilize the hands. And in the late stages, there's actually atrophy, so thinning of the skin tissues. And on the other photo, we again see symmetric involvement of all the fingers kind of progressing up to the wrist. Now we can also see up top, there are the little ulcers that occur on the fingertips. It's very characteristic finding, and sometimes they can be quite painful. And down here we have an example of an ulcer that happens on the fingertips too. Very painful usually, very difficult to heal. We'll talk about some treatment options, and sometimes surgery is required as well. And then this is something that your doctor might be looking at. So this is a magnified view of the nail fold. So around the nail, we're looking at the capillaries. And again, as Dr. Cameron nicely discussed today, the vascular involvement, or the blood vessel involvement, is a big part of the pathogenesis of scleroderma. And so this provides a window into what's happening in the capillaries everywhere else in the body. So what we see is, with the arrows pointed, the capillaries get big, and there's also loss of some of the capillaries. And so that kind of mimics what might be happening in the lungs or the kidneys, so the other organs that are involved. So let's now dive into treatment for some of these common manifestations. This is Raynaud's, as I'm sure many of you know, where the fingers go through 3 phases. So when there's cold, the fingers will be white, like pure white as shown in the photos, then blue, and then red again. And again, it can be quite painful. Some patients can have many attacks throughout the day. And so we really need to have good strategies to address this. And some of you have those nice scars with the mittens, so that's a good first step, because you should try to avoid cold as much as possible. Always pack gloves in the winter time so you're not stranded outside without having something warm for your hands. Smoking can affect the little capillaries as well, and so combining the autoimmune process with smoking really accelerates things and makes it worse, so stopping smoking is quite important. And you can also look into getting the heat packs for the hands, or warming gloves, or warming socks for the feet. Now if those options are not enough, usually the next step is systemic medication, so a pill, which is a calcium channel blocker, but that's usually a blood pressure medication that also has some evidence to help with the Raynaud's. And then down the road, if none of those options work, we have some more advanced medications which help to dilate the vessels. And what I wanted to share with you is some new research in the area of Botox. So So a lot of you might be familiar with Botox as a cosmetic treatment for wrinkles. But the way that it works is it's injected into the muscle to relax the muscle to then help the wrinkles. So the same thing can happen with the muscle of the capillaries. If we do the injections, so the 10 injections, 2 per finger, we can relax the muscles around the capillaries so when there's exposure to cold, they don't constrict as much and lead to Raynaud's. And this is a very impactful photo on the right. It's kind of like a heat map. And on the left-hand side is before treatment, on the right-hand side is after treatment, and there's examples of 3 patients. So on the left-hand side, we see there's a lot of blues and greens, which is the cold temperature, and after treatment with Botox injections, it leads to more reds and yellows, which is warmer temperature. And clinically, we've been able to do this for a number of patients, and we have found it quite effective. And there's a question.
I just want to know at what point, like somebody's had it for a couple of years, is it still effective too?
Yes. Yeah, it's because it really targets that mechanism of relaxing the muscle around the blood vessels, so it can really work at any point of the disease process. It is something that needs to be done usually every 6 months, but we find that the more we do it, the more we can space it out over time, so it might move to every 9 months. The challenge with this is, of course, cost, because Botox can be quite expensive. So for patients that may have access to private insurance, what we've done is we usually send a lot of research articles proving that this is an effective treatment, and hopefully get the cost of the medication covered that way. And hopefully in the future, it can be on the public formulary to cover the cost as well. So let's move on to the next manifestation. So this is calcinosis cutis, or calcium deposits, that can happen most commonly on the fingertips again, but it can be any area of the body, so the elbows, knees, sometimes even forearms and thighs. And these, especially on the fingers, there can be a lot of them, they can be very, very painful. And the treatment options for this are quite challenging. Sometimes surgery is considered to cut out those individual deposits. The blood pressure medication we talked about for Raynaud's could be helpful for this as well. Sometimes a medication called bisphosphonates, which patients may be taking for osteoporosis, could help this as well. But I wanted to share some of the other strategies that have case reports in the literature. Oh, I'm sorry. This is the right, not the right slide deck. Is it okay if we take a 2-minute break just for me to update the correct slide deck? I'm so sorry. I want to have the right information for you. Well, now we're back. It would be too good if everything went smoothly. I'm very sorry about that. But now I have the right slides to share the right information for you. So one of the treatments for the calcinosis cutis is something called sodium thiosulfate. And it can be administered in both cream form and injection form. So this is an example of a case where a patient used 20% concentration, which is just mixed in to Vaseline. This is not a medication that's commercially available. The pharmacist has to manually mix it together. And it can be applied 3 times a day, ideally under occlusion, so saran wrap or a Band-Aid. And then for this patient, we see that in 2 months there was improvement in pain, and in 3 months of use, that calcium deposit resolved and left the pitted scar that we saw before on the fingertips. And in terms of the injection form, we can inject the sodium thiosulfate into the fingertips. And you might think that that's very painful. And so what we do is we usually numb the whole finger so that the injections are well tolerated. And the injections can be repeated on a weekly basis and sometimes stretched out to every 3 months. And so an example here is of a patient treated with injections weekly to every 2 weeks, 6 times. And we see a dramatic improvement in the calcium deposits. And of course, that coincides with significant improvement in pain. Now let's move on to the facial manifestations of systemic sclerosis. So this is microstonia, which means decreased mouth opening. And this can be a challenge for many patients with scleroderma, especially when going to the dentist or having dental procedures done, because the mouth can't open as widely as it used to. And so here, this is some new data using hyaluronidase injections to help dissolve the scar tissue or the extra collagen around the mouth. You may know hyaluronidase. It's something that's used to dissolve filler for patients that are again using it for cosmetic reasons, but it can also help to dissolve the collagen. And so usually here, it's a number of injections that happen around the mouth, usually at intervals again. And so we see on the top part of the photo is an example of a patient that had 7 treatments performed. And then on the bottom part is an example of a patient that had 2 treatments performed. And we see the dramatic increase in the mouth opening following the treatments. This is an example of a patient when I trained at McGill. So at McGill, there's a skin fibrosis clinic that runs, and we see a lot of these very challenging cases. And so this is an example of our patient, and we see an improvement in the mouth opening over time as well. So telangiectasias, which is dilated blood vessels that occur on the face, is another very, very common manifestation, especially in the limited form of systemic sclerosis. So it can occur on the face, it can also occur on the tongue, and can happen on the palms. And so because these are dilated blood vessels, it also kind of provides a picture of what's going on internally with the smaller capillaries of the organs, similar to what we talked about for the nail fold capillaries. But this can be treated with a vascular laser. So a laser that specifically targets the blood vessels, heats them up, and blocks them off. It's quite effective to treat the vessels that are present at this point in time, but over time more vessels can develop because the disease is still in the background, and so it could be retreated. And this is an example of another patient that had a lot of these telangiectasias, and then there's significant improvement with the treatment. Now, another manifestation on the skin is something called the salt and pepper pigmentation. And associated with this, there can be loss of hair, there can be decreased sweating, and also significant itch for the skin. And this can be very troublesome appearance, and so patients may often be hesitant to wear shorts or short sleeves if it's affecting their arms and legs. There are no good treatments for this, but as we talked about earlier, the mycophenolate mofetil, which is one of the immunosuppressive agents that might be used to treat systemic sclerosis, has some evidence for helping with this manifestation as well. So as I mentioned, there's a lot of skin dryness because of the fibrosis that's happening in the skin, and that also corresponds with significant itch. So I just wanted to go through some of the tips that I usually recommend for patients to take care of the skin. So we usually recommend wetting the skin once a day. That can be in the shower or with a wet cloth. And immediately after that, applying your treatment creams first and then moisturizing cream on top from head to toe. In terms of the showers, they should be short, so less than 5 minutes, because longer showers may feel nice, but they dry out the skin more. And similarly, it should be warm water, not hot, even though everybody loves a hot shower. That contributes to more itch and more dryness over time. In the wintertime, the skin gets dry because of our dry climate. So moisturizing those very resistant areas or very dry areas twice a day, or even sometimes 3 times a day. And then in terms of the shower, we usually recommend avoiding soaps. People like to scrub their skin with soap, but that can be drying for the skin, and we don't actually need a soap for the skin unless it's visibly soiled. So just water is sufficient for the skin, and if you want to use something, a gentle, non-foaming cleanser can be good to cleanse the skin without drying it out. And then in terms of the medical treatments, kind of for the fibrosis in general, again, as we discussed, there's no amazing treatment options at this point in time, and we often have to combine many things together to have the best benefit. So of course, if there's significant itch or even a dermatitis or eczema picture that develops, we can use topical corticosteroids to reduce that inflammation. There are some non-steroidal treatment options, such as the calcineurin inhibitors, and I included some brand names, Protopic or Elidel, in case you're familiar with that. Phototherapy is an option as well, and I looked into this, and there's a couple centers in Winnipeg that do offer phototherapy. It's this booth, as you see in the photo, where the light shines on the skin for a couple minutes at a time, and it's anti-inflammatory for the skin. So the narrowband UVB, which may be more accessible, will help with the itch. The PUVA, which I'm not sure is available here, but that penetrates a little bit deeper into the skin and can help break down that collagen and that fibrotic tissue as well. And then in terms of systemic treatments, so again, we had this discussion earlier this morning, and typically, even if patients have only skin involvement, if it's quite extensive, we typically proceed to starting systemic treatment because we want to prevent the process from progressing further, because we know that over time, especially for the hands, there can be strictures and inability to open the hands. So we want to start the treatment as early as possible. From our experience, we find the mycophenolate mofetil helps a little bit more with the fibrosis, but methotrexate could also be an option. And then following our discussion this morning, I just added this bottom part. This is from the European guidelines for the treatment of systemic sclerosis. And so they have some new updates. So methotrexate and mycophenolate mofetil, but then rituximab is another treatment option that can help with the fibrosis. And then the tocilizumab, as we discussed, might be helpful for inflammatory, early, and progressive cases too. Of course, we touched on this in the morning, but we need to think about the systemic organ involvement. Skin is often the first presentation or something that's visible, and we may make the diagnosis first, but then we have to work with our collaborators closely to ensure that all the different organ systems are assessed and followed. So we can think about the lungs, and we can do pulmonary function tests and a CT scan, and lung involvement is quite common in systemic sclerosis and a very important one to follow. In terms of the heart, the echocardiogram regularly. In terms of the kidneys, monitoring blood pressure, making sure the blood pressure is in a good range. Blood pressure is something that you don't feel, but your capillaries and vessels feel on a daily basis. So taking that blood pressure medication, if it's recommended by your doctor, is very, very important. And monitoring kidney function through other methods. And then the gastrointestinal tract involvement, also very common, and also there's some tests that could be done. So now that we've talked about the presentations and some of the treatment options, let's actually go all the way back to the beginning and think about what do we know so far about how or why systemic sclerosis develops. So this is a very busy slide, but this is what we know. There's an individual who has some genetic susceptibility for autoimmune diseases. And then there can be many external factors in their outside world that comes into play. So starting from the top, asbestos, for example, is an associated factor. Occupational factors like pesticides, silica, and organic solvents, which we'll talk about in detail shortly. Air pollution. There's a number of infections, like viruses mostly, that have been hypothesized to be related. And some medications, especially chemotherapy agents, that can trigger the skin fibrosis. So all of these factors are at play, and then that's what leads to the three-step kind of pathway that we alluded to this morning. So initially there's damage to the little capillaries, then there's inflammation that forms because of that, and over time this ongoing cycle of inflammation leads to deposit of collagen and that thickened tissue. So how common is systemic sclerosis, and what are some of the triggers? So this, for the second part, I will talk about the research that I've worked on throughout my PhD on this topic. So of course, to be able to conduct big studies and get ideas as to what could be the trigger, we need large sets of data. So this study was done in Quebec because for every patient at every clinic visit, there is a diagnostic code that's assigned. So we can identify all the patients in Quebec that have had a diagnostic code of systemic sclerosis. And so in this cohort, we identified 8,000 patients that had the disease over about a 20-year period. And then we looked at the trends. So what happened between 1996 to 2019? So we see that there is a steady increase over time. On the left-hand side, we see the incidence, which is the number of new cases diagnosed every year. And on the right-hand side, it's the prevalence. So it's the number of cases that exist in the population any given year. And so both new cases are rising, and of course, for getting new cases, the prevalence is rising as well. So there was about a 4% increase per year that was noted. And this again parallels what we see for the other autoimmune diseases. So there must be something at play leading to this increase over time. Part of the reason could be better disease recognition. This wasn't as well known 30 years ago, and it's better known now. But given that it parallels those other conditions, likely there's something going on. And of course, as we discussed, for females, higher rates compared to males. Now, in terms of mortality or deaths as a result of this condition, it's very reassuring that it's decreasing over time. It means we're better at diagnosing the condition, better at treating the condition early, and preventing the complications. However, if you look at the bars, it's still about 2 to 3-fold greater than the general population. So there's still quite a lot of work to be done in this area in order to treat the disease more effectively. And then we looked at the geographic distribution. So this is very interesting. For diseases that are rare and we don't know the triggers, this is often the first step to generate hypotheses. For example, now we all know that asbestos is bad for us, and it can cause a type of lung cancer called mesothelioma. But that was actually identified in a similar way because they found a number of cases clustered in certain areas, particularly in Australia and Italy, and then they looked into those areas more to see why is this happening. And they found that it was located near mines that had asbestos. So here we're looking at our data through Quebec, and we mapped it to see where the hotspots are. The other reason to identify the hotspots, in addition to generating hypotheses, is to then target kind of education and resources and perhaps earlier screening to those areas. So over here in the province of Quebec, on the east side of it, we see more red areas there, so higher number of cases. And then when we look in detail in the greater Montreal area, even though Montreal is a very urban area, it's not homogeneous. We still have some areas where there's more cases than others, and we need to look at the reasons why. So this is very preliminary work. It's not published, it's not fully completed yet, but I just wanted to show an example of what we could do with this type of research work. So we looked at the geographic distribution, but we also have data on the air pollutants and emissions and chemicals, also divided by each geographic area that are measured and reported publicly. And so we combined our number of cases to the areas, like the corresponding areas, to look at the air pollution and things like that. And we put it all into machine learning because it can handle large volumes of data, which this data is. And we found a couple of factors. So toluene, which is in paints and solvents that can be released from large industries into the environment. This chemical, which I cannot pronounce, but it's an old refrigerant. Now we don't use it as much anymore, but some of the older industries might be emitting this into the atmosphere. Formaldehyde, which is in building materials and indoor air. And then interestingly, heat waves. So the areas that saw more heat waves also paralleled the number of cases seen. However, comes with a grain of salt. This is not causality. It does not mean for one particular patient exposed to this that it leads to disease diagnosis. This is on a population level, just looking at the geographic areas. It just helps to stimulate hypothesis and to look into this further, but we can't say that this is a trigger for any person in front of us. So then we looked at the similar things in a different way. So here we actually use the Canadian Scleroderma Research Group data. And there's a center in Montreal, there's a center in Montreal, there's a center in Winnipeg that is also kind of collecting data on patients locally. So if any of you have contributed to this registry, thank you so much, because this is a way that we can get large volumes of data and then study it to better understand the disease, the counseling, and the treatment down the road. So the blue stars here indicate the recruitment centers, and then similarly we see some areas of hotspots. It's hard to see to this zoomed out scale, but of course we see urban centers that have more cases. But interestingly, there's a couple of red spots that are quite far from urban areas and far from recruitment centers. And so those are particularly interesting to see what could be going on there. So using this data, we did an interesting kind of model. So on the left-hand side is the number of cases of systemic sclerosis that we would expect given the population number, and the general prevalence of the disease in Canada. And on the right-hand side, we looked at our data. And so we see that there is significantly darker red in the truly observed compared to what we would have predicted. And we're not sure why that is. So in that study, we modeled, we had an overlay with industries and mining. So the green is industry, and as you may know, Hamilton is a very industrial heavy area, so there's a lot of industries nearby, and a couple of mining sites as well. And the pink cloud outlining the whole thing is a 5-kilometer radius, which is usually the distance that we look at environmental factors. And so we see that we observed way more cases than we would have expected, and we see that there's heavy industrial density. So again, could this be an association? Similarly, we see this for Montreal, the greater Montreal area. And for example, in Beaconsfield, we expect a low number of cases, but then on the right-hand side, we see it's deep red, so a lot more cases than we expect. And now, let's dive into talking about the occupational triggers, so something that patients may be exposed to at work. So first, we'll start by silica. And silica is important to study because large pooled studies from across the world showed an 18-fold increased risk of developing systemic sclerosis with silica exposure. And so for this study, we again used the Canadian Scleroderma research group because then we had details on each individual patient, what their occupation was, what were the internal organs that were involved, and then we could see if there is a correlation. So the reason that we wanted to study is because we don't know how common silica exposure is in our Canadian cohort and in North America in general. It's unclear whether exposure is associated with certain more severe disease features, and we also don't know whether somebody who has had exposure, whether we need to do screening for internal organ involvement at different intervals or other ways of screening. So silica can be encountered in many different occupations, usually very dusty occupations. So glass cutting, gem cutting, mineral crushing machine operator, and miners as well. And so based on Canadian data, about 430,000 Canadians are exposed to silica through the occupation. And aside from occupational exposure, this could also be through indoor exposure, but that is much more difficult to characterize and we can't quite study. So in terms of the results, we had about 1,500 patients in the registry, so all across Canada, with about 90% being female with an average age of diagnosis of 46 years old. And 7% of the cohort reported exposure to silica, much more common in males compared to females. And so for our results, the patients were diagnosed at a younger age if they had silica exposure, and they were more likely to be males. And in terms of the severity of the disease, there was more association with diffuse skin involvement, worse lung function, and more gastrointestinal symptoms. And again, we found that the patients exposed to silica also had high rates of smoking, and so both things combined together really don't have a good outcome for the lung disease portion. So if you've had exposure to this throughout your occupation, this may be an interesting discussion to have with your doctor. And if at all possible, we usually recommend reducing the exposure, wearing protective equipment at work and being more diligent with it, and discontinuing smoking if that's relevant. And then we looked at organic solvents, which is another possible contributing factor, and there's a 2 to 4-fold increased risk of developing systemic sclerosis with organic solvent exposure. So these are carbon-containing liquids. There's many different kinds, and in the past they have been associated with autoimmune rheumatologic diseases. The occupations where this comes into play is laboratory work, dry cleaning, paint and glue industries, tire industries, leather industries, things that use a lot of dissolving agents. And so For the diagram, it can come in contact through the skin, it can be inhaled, it can be ingested, and then over time, it can lead to involvement of different organ systems. So here we found it was more common than silica. Silica was 7%. Here, 20% of the cohort reported exposure to organic solvents through their work. And again, patients were more likely to be male and to have a history of smoking. And then we looked at association with some disease features. And so there was more involvement of the gastrointestinal tract, more kidney disease, which is new, that hasn't been reported in the literature before. And there were fewer antibodies, which are associated with better disease prognosis. So overall, again, signals towards more severe disease with this occupational exposure. So in the clinic, when I see patients, I usually like to ask this question to everyone, whether they've worked in a dusty occupation and what they do for work to better characterize if they've been exposed to silica and organic solvents, because that can help me tailor my discussion. And I also, because we've now seen that there's potentially more severe disease features associated with exposure, I will be screening for those internal organ manifestations at more frequent intervals. And we didn't talk about this, but occasionally some medications, especially the chemotherapy agents, could be associated with development of fibrosis, so getting a detailed medication history is also helpful. So I would like to say a big thank you to all of you for being here, to Joanne for inviting me to present here and share some of the learnings that I've had over the years, and to these granting agencies that helped support the research work that I presented here. And I'm happy to answer any questions.
This industry you study are going to be primarily men, because who works in mining? I mean, it's going to be 90+%.
Yeah.
So is there any studies contemplated on where women work more?
So there's, no studies like that. Oh, repeat the question. So we see some association with occupational exposure, and it's the occupational exposure is more common in males, and that's what we're seeing in the studies. But is there studies that in females there's more exposures and what that entails? Is that correct?
Yeah. Well, like nursing, for instance, you'd have 80% female.
Yes.
And you've got a situation where 80% more females get scleroderma than males.
Yeah.
So to me, it's like,
relationship.
I know what you're saying. So it is much more common in females, and of these patients, like the vast majority were females, and we asked everyone for their occupation, but females were less likely to be in occupations where they might be getting this type of exposure. And so that's why we're seeing the patients that have systemic sclerosis and have an exposure are more likely to be males, because males, if they didn't have the exposure, perhaps would be less likely to develop the disease because it's more rare. Does that answer the question? We can't quite look, I suppose we could collect a set of female patients that had these occupational exposures and study just for them what the internal organ involvement would be, but already we're at about 1,500 patients, and if we get into those, we'd have very few patients. So we definitely need more data, but that's an interesting question to consider in the future.
I was wondering about the vascular laser for telangiectasia. I haven't heard that even discussed by my rheumatologist. How is something like that approached by somebody that has telangiectasia?
Yeah, so definitely a good question to ask your doctor now that you've seen it. Typically it's completed in more of the dermatology clinics where we have access to laser. And the lasers work quite well, and there's a couple of different lasers that can work for this reason. The challenge is that I'm not sure what the coverage is in the province of, in this province. In Ontario, we can actually get coverage for the cost of the laser for a medical indication like this. So it's not considered cosmetic, it's really considered for medical reason. I'm not sure what the coverage is, but potentially the cost could be the limiting factor. But yeah, it would usually be through a dermatologist office.
So you would go through your rheumatologist to get recommended to a dermatologist?
Yeah.
Okay, thank you.
Yeah.
So maybe things have changed, but I heard that about
it is for dermatologists to be interested in scleroderma? Are you a rare person as well?
That's a great question. Unfortunately, yes, it's not as common for dermatologists to be seeing systemic sclerosis. Over kind of my training, as I mentioned, because of the personal background and family member, I have really shown an interest in this over my training. So at McGill, we did the skin fibrosis clinic where there's only one other dermatologist that's very interested in this. And then in Toronto, I think I'm one of the only ones, but we work very closely with the rheumatologists, and so rheumatologists are often the ones starting the systemic medications if that's the case, but then we're happy to see the patients, and then I'm able to kind of do some of these other treatments that we talked about that others may not be doing.
So coming back to that whole interdisciplinary team, and so we've got a rheumatologist, we've got a pulmonologist, we've got a gastroenterologist, a cardiologist, who else do I see? And now I can have a dermatologist.
Yeah, and I was surprised with the John Hopkins Fellowship that you presented. There's no dermatologist there, but I think we have a lot of tools that can also help with some of these skin manifestations that are often very prominent. So hopefully dermatology makes it to the list. And I'd love to have like a multidisciplinary clinic set up because we know that that's much better for patient care. And I'd love to set that up where I'm practicing. It is logistically very challenging to run these clinics though.
I just wanted to tell the group, one of our board members is Manu Jagdeo, who is a physician who has just started his residency in dermatology. He's on our board. So we might have one here in Winnipeg.
That's great. He should come visit our clinic and we'll teach him some of these.
Yeah, exactly. Yeah, exactly. We need to maybe sponsor him. Anyway.
Yeah. And there's a question back there. Oh, yeah.
Maybe silly question, but what makes some people more susceptible to environmental factors than others? Is there
That's a great question. The answer is it's not well defined, but it comes back to the genetic susceptibility. So everyone is exposed to all these factors every single day, and there's different changes that happen in the DNA, some breaks, some mutations, and most of the time our immune cells clear those problematic cells, but sometimes when the cells have stuck around for a long time, it triggers this autoimmune process, and that would really come down to genetic predisposition and possibly kind of luck as well, but it's not well defined at this point.
if you recognize those triggers early enough, could that slow?
Great question. Oh yes, the question is if you recognize some of these triggers early enough, can you prevent kind of disease progression and factors? It's a great question. I wish I had more solid answers. The answer is we don't know. We're still trying to understand the triggers, and after understanding the triggers, then we can see if that makes an impact long term if we intervene early. Mechanistically, it would make sense because what happens with autoimmune diseases is there's often some kind of trigger and it gets your immune system into overdrive. And we see that if you remove that trigger, the immune system is already in overdrive and kind of continues. So likely the disease process would continue to some extent. But the issue is if you're constantly exposed to that on a daily basis without removing the trigger, it makes the immune system a lot more active and potentially like the worst disease manifestations that we see. It likely wouldn't be able to prevent it altogether, but hopefully milder form.
One of the other things on your research was that the onset was age 45-ish?
Yeah, in our cohort it was about 50 years old in patients, but in general it's 20 to 50, it's a big range.
Right, but the overall population, what's the normal onset?
So 20 to 50 years old is what's reported in kind of big pooled studies from across the world.
Okay.
In the Canadian Scleroderma Research Group, where we have the 1,500 patients, the average age is 57 years old.
I was encouraged that not only is a dermatologist interested in scleroderma, but you are in fact an epidemiologist as well. And I was really interested, I think this is one of the first times that we've had a really systematic description of some of the triggers. And so thank you for that. I think that was, I just want to encourage you to keep up that work. There's two little things that just makes me think about is when you looked at Hamilton or Montreal, did you normalize that for income? Because income is such an important it dictates health outcomes. And the second thing that I think about is we're in an agricultural heartland here. We grow a lot of wheat, and wheat straw has silica in it. And we have, the beautiful harvest moon is really dust in the air. And so it makes me wonder, as somebody who threshed wheat yesterday, how that works. But my first question, I think, would be the most useful one.
Yeah, that's a great question, great observation. So we did not adjust the NATCD for socioeconomic status. It is important for studies like this to adjust for all the possible confounding factors. And back then, that was the early, I didn't present it in this way, but that was the earliest study that we did. And so we didn't have access to kind of machine learning yet. And in the future, when we kind of finalize our study using all of Quebec data and using machine learning, we will adjust for all those factors because it's a very important confounding factor. And we can't really do it with traditional statistics. We really need these large models that can process all the different factors and have like a predicted associated factor.
In your slides of the geographic areas and the densities of scleroderma, you mentioned there were a couple of areas that were more remote, and I wondered if you had any thoughts on what might associations.
Yeah, that's a great question. Again, because we weren't able to have this machine learning model, which now I think will really change the way we study this, we kind of looked at it just on a map, seeing what are the industries, what are like the big things going on in those areas, and they're usually industries and mines. So a couple of those places had big steel industries, so potentially emissions from that could sort of explain it. But that work was very much hypothesis generating, and we need to look at it in much more detail, account for all the confounding factors to be able to draw conclusions.
I'm just curious from a dermatology perspective, like we hear a lot about the skin thickening, we don't hear a lot about the atrophy phase, which is actually, I guess, not just returning to normal, but actually thinning beyond normal. Can you speak to that?
Yeah, it's a great question. How do I explain this? So with the thickening, there's often limitation for the hands. Let's talk about the hands to kind of do this over time. Atrophy is when the collagen actually breaks down a little bit. So it's not really thinning more than normal skin, and it's not really going back to normal skin. It's sort of this other kind of hybrid presentation where we can actually pinch the skin. It's not rock hard, but it still has some fibrotic features to it, so there might still be some limitation in the range of motion. Yeah. And there's another question?
Well, I was going to ask you this question, but I thought I would ask Dr. Google because I didn't want to waste your time with it. But do you know if OSB board contains formaldehyde?
That's a great question.
I'm going to look it up.
Yeah.
Yeah, okay. I'll let you know.
Okay, let me know. Yeah.
Well, that's neat. We are so blessed to have Dr. Shane, Dr. Anastasiya here. Thank you so much for all that you guys do. I'm wondering on that busy chart with all these factors around there, and this cocaine and vitamin D, we're right beside each other. And in the last couple of years, we've been told vitamin D is the new vitamin C. So, can you tell us something about that? What was going on there?
Yeah, I mean, they're not meant to be right next to each other. They're sort of, they're just in the category of kind of personal exposures. The cocaine is easy to explain because it constricts the blood vessels, and so again, it comes back to that vessel pathology. In terms of the vitamin D, we kind of did a huge literature search to see things that were reported. There's very few studies on vitamin D. Vitamin D is considered good at regular doses. It was really the very ultra high doses of vitamin D that have been linked, but again, so many confounding factors in these type of research projects, there could have been other factors at play. Yeah.
OSB does contain formaldehyde. And all of our houses are built with OSB across Canada.
Okay.
That's the plywood we use.
Yeah.
Very
And
good at food.
yeah, so with the we talked about the environmental exposures, but we also need to think about the local exposures like in our homes. But the problem is it's impossible to study that. It may vary across houses. We don't have that data. No one's measuring these things in their house. So that's another challenge to all of this.
Isn't there tests? I know we did tests in our own home about the air quality and whatnot. What was it called? Do you remember? Radon, sorry. Yeah.
Gas,
Yeah. Is that related or?
Great question. I'm actually not familiar with that. So it's not definitely a common thing that's reported in the literature. And I don't know, that would be an interesting thing to study because a lot of people are looking into this in their homes and a lot of homes do have some radon exposure. If we have access to kind of data, whether it's the government or somebody who would track these levels, then we could potentially incorporate that into our studies. But from what I'm familiar with the literature, it hasn't been studied or reported.
Are we finished with questions? Okay, so thank you very much, Dr. Muntyanu. I keep trying. Anyways, so scleroderma is very challenging, and you provided us with lots of information, and we're glad that we got to have a conversation with a dermatologist. That's new for us, and you give us hope for the future. So I'd like to